morning, seniors. Bet you're wondering why you're hearing my voice on this recorded lecture. Well, best laid plans. I advised Miss Smith to get her own podcasting microphone and record a lecture to fit this one in after the snow week you had and the break that we all couldn't afford to take. And so she never did get around to buying a podcasting microphone and asked if I would do this recording for her. And so here we are. And so this is my presentation of your Chapter 10 Pathology Endocrine System chapter. And away we go. All right. Oh, that font's way too small. All right. These are objectives straight from your syllabus. We are going to talk about pathology of a particular body system, the endocrine system. We've got about 4 or 5 glands or organs to visit: the thyroid gland, the pituitary gland, the adrenal glands, and we're going to talk about common pathologies with them. Some of them are going to be additive, some of them are going to be destructive. Some of them affect themselves in the way that the gland itself, like the thyroid, presents on, in particular, a nuclear medicine study. But some of them, like the parathyroid glands, affect the presentation of the bones. And we'll see a lot of changes to other areas of the body, either hyperdevelopment, hypertrophy, special types of hypertrophy, and special types of atrophy, in particular related to the pituitary and the thyroid gland, as we talk about those particular glands and their associated pathologies. Anatomical and physiological effects of disease on the human body. So while we're describing these conditions, we're going to describe the changes from normal structure and function that you see manifest with some of these diseases, and how does that impact or affect, if it does at all, the way you perform a radiographic exam on someone suffering from these conditions. Okay, probably the most common is going to be circulation issues to the lower extremities with diabetes mellitus, which we're going to get to at the end of the chapter. I apologize in advance for the gross pictures. If you've never seen gangrene, brace yourself. You're about to see this by the end of this lecture. But it's good to recognize and good to be gentle with those diabetic feet because it is tissue necrosis. And now the nice thing about it is the nervous system shuts down and they don't feel the pain anymore, but unfortunately they are going to end up getting body parts amputated if they have gangrenous feet due to diabetes mellitus. Okay, and I'm not sure if I'm saying mellitus right. It might be pronounced totally differently. Ask Mr. Shepard to be sure. Okay. And so I did mention nuclear medicine. We're going to look at some plain radiographs. I think there's some ultrasounds and CTs in here too for the various glands and their pathologies. And we got some representative imaging studies to show you the changes and how we can spot a lot of these pathologies on imaging studies, not just plain X-ray, but other modalities as well. Okay. Yeah, understand and appreciate the radiologist's role in collecting patient information. And so, yeah, your radiographs are often going to tell the story, but again, the lost art of taking a patient history is going to corroborate some of your signs and symptoms, some of your signs and the patient's symptoms corroborate the radiographic evidence and give the radiologist a little bit clearer picture as to what is truly going on, and kind of locks in that diagnosis and makes it more of a sure thing, so to speak. So the history taking is very important. All right. Okay, so we're starting out with the adrenal glands. The adrenal glands, adrenal means on top of the kidney. So the name adrenal tells you exactly where they're located. They have an outer cortex and an inner medulla, okay? The cortex secretes several different types of steroid hormones, okay? You have your mineral corticoids, which regulate salt and water balance, okay? I wear those out because I have a salt tooth. Glucocorticoids, that's the other thing Americans struggle with, is regulating carbohydrate metabolism. And so your adrenal glands will assist with the absorption and metabolism of carbohydrates. And this would be in the extracellular spaces and in the individual body cells. This would not be supporting metabolism in the GI tract. Both of these, mineral corticoids and glucocorticoids, the action is in the bloodstream, but more particular in the extracellular space, because that's where a lot of our body cells get their nutrients. So, and then androgens. Androgens are precursor hormones to, in particular, testosterone, but there's other. So the one that I know, it was kind of, when I was in college, they made it available to weightlifters. It wasn't really steroids, but it was the precursor to a steroid. It was called androstenedione, and it is an androgen secreted by the adrenal gland. But you can also go down to GNC and buy it in powder form and stir it into your protein shakes. If you are a male and your metabolism is running correctly and you have proper nutrition, extra androstenedione in your system will convert to extra testosterone. So, so they masculinize the body. You retain more amino acids. You don't excrete as many amino acids when you have these androgens in there. And that allows you to have more reserve amino acids to build more proteins, which is what your skeletal muscles are made out of. And so it supports secondary sex characteristics and the development of larger muscles in the male anatomy. Ooh, I feel a sneeze coming on. Gotta pause. Hang on. All right, I'm back. I did have to sneeze. Apologize for the delay. No, there was no delay for you. It was a recording. Anyway, normal physiology, keep going. We know that it secretes epinephrine, also known as adrenaline, but then also norepinephrine, which is the antagonist hormone to epinephrine. So epinephrine is your fight or flight response. It's getting up on a level. You're either going to get aggressive and prepare yourself to throw hands, or you're going to get terrified and prepare yourself to run as fast as you can. Both of those useful in high stress situations, high threat situations. But then you do need to calm down eventually after the danger is removed, and that's the function of the epinephrine. Okay, epinephrine increases your heart rate, which in turn increases your blood pressure, and pumps more blood to your skeletal muscles, and it can go over where you just have a bunch of nervous energy and you start shaking in high stress situations. You can also, if you find yourself in lots of high stress situations and you have anxiety, you can actually find epinephrine makes you kind of jittery and shaky and not able to function all that well, because you really want to punch something or you really just want to run, but it's not a threat of physical harm. So we find that in the modern, that's one of the reasons stress is such an awful thing in the modern world, is because we get stressors and our brain and our subconscious still thinks we're hunter-gatherers and there's a saber-toothed tiger And so we dump enough epinephrine into our system in a high stress situation where we're ready to either run from or fight a saber-toothed tiger, but it's not that at all. We're just late on our taxes. So puts a lot of stress and strain on the circulatory system when we stress react to things that are not true physical threats. So norepinephrine, in order to antagonize the effects of epinephrine, it's going to dilate your blood vessels to allow for blood pressure to come back down. It is going to allow blood to swell into the capillary networks where it's most useful, but it also drops your blood pressure. Stimulates heart activity. Your heart starts beating faster, which raises your blood pressure. Okay, and it also triggers the secretion of blood glucose. Okay, from storage reserves. Typically, those are your what are those called? The fat cells, not lipids, or I forget the name of the cell, but I know lipid is fat, so you can actually dump, if you have the right enzymes, you can dump fat cells into your bloodstream, burn fats, send them to your liver. They can be converted to glucose, sugars, and then secreted into your bloodstream. So it shunts blood to active muscles where oxygen and nutrients are urgently needed. So that means lots of blood to your skeletal muscles. And it constricts and dilates specific blood vessels. So blood vessels in your mesentery, not so much. Okay, you might. That's where the phrase "gird your loins" comes from. It's wrapping yourself in tight-fitting clothing around your abdomen. But when the epinephrine dumps, you kind of tighten up your rectus abdominis, and everything in your abdomen gets tight. Part of that is the smooth muscle gets tight, and you actually reduce the blood supply in the mesentery and around the small bowel to give you more blood volume in your extremities, your arms and your legs and your skeletal muscles. So, pretty handy feature. Glad that hasn't completely disappeared from the evolutionary model. Okay. Now, let's talk about pathologies. Cushing syndrome, excess production of glucocorticohormones, okay, which causes fat redistribution in the body and other effects. So when you don't use all your carbs, you do store them as fat. That's part of the natural physiological process, okay? But if you have too much glucocorticoid hormone, you're going to ramp up the fat storage process, and we'll see that in the next slide. Aldosteronism, I don't know if I'm pronouncing that right or not, overproduction of mineralocortical hormones due to an adrenocortical adenoma, or bilateral hyperplasia, which is abnormal, I think it's abnormal number of cells in the adrenal glands or in the cortex layer of the adrenal glands. Okay. Other causes include renin secreting tumors, renal artery stenosis, malignant hypertension, and bilateral chronic renal disease. Okay. All right, so here is Cushing syndrome. Oh Lord, we could have done without that drawing. We could have used our imagination. So upper body obesity with thin arms and legs, a buffalo hump, a red round face, high blood sugar, high blood pressure, vertigo and dizziness, blurry vision, acne, loss of hair in females that suffer from Cushing syndrome, water retention, menstrual irregularities, thin skin and bruising, purple striae, which are kind of like, I think the old folks call those spider veins, poor wound healing, severe depression, cognitive difficulties, emotional instability, sleep disorders, and fatigue. Does not sound like a good time, and it definitely adds to the thickness of the body, especially in the torso and the lower abdomen. And so Cushing syndrome patients, you will need to increase technique. It is an additive pathology. It affects mostly the torso, but the entire body. If we do a study, now this is a tomogram, nephrotomogram, which is a slice through the kidneys. The old x-ray machines could do like a 20 to 30 degree arc and do slice cuts, plain x-rays, but slices through the kidneys. And this is in the middle of an IVP. We've got contrast in the right kidney and the left kidney. You can see bright white contrast there. We can see the calyx network, kind of blurry, but we can definitely see the renal pelvis on the right. You can see the psoas muscles. And so this is supposed to be a slice right through the plane of the coronal plane that passes through the kidney. So probably about 2 inches posterior to the mid-coronal plane. And we can see a large adrenal adenoma indicated by the white arrows over the left kidney. It's actually displacing the left kidney inferiorly and kind of crowding it. So yeah, that is a big tumor there. Okay, Cushing syndrome, the thing about the adenoma tumors, the cortical adenomas, they're still functional. And so you have a hyperplasia or a regional hyperplasia, which is a nice way of saying a benign tumor that's still functional tissue. So what does the adrenal cortex do? It secretes those corticosteroids, the 3 corticosteroids we covered on previous slides. And so you get an abnormal amount of those corticosteroids. In particular for Cushing syndrome, you're getting the one related to carbohydrate metabolism, and so you're storing excess carbohydrates. Okay. Adrenal carcinoma, now we're definitely talking about cancer. That's the prefix there. So breaking that word apart, adrenal, pertaining to the gland above the kidney, carcinoma, a tumor that is cancerous. And so we have CT and ultrasound diagnosis of these. Ultrasound not as clear as always. Take that, Mr. Shepard. But on CT, we can definitely see the adrenal carcinoma, and we can distinguish it from the previous slide because it has focal areas of necrosis. You see how it's got the mottled attenuation effect there, where it's inhomogeneous, is what they say. What does that mean? It's made up of different attenuation colors. So it's got a mottled appearance where it's like speckled. You notice how it kind of looks noisy, but the rest of the anatomy doesn't look noisy. Well, that's not noise. That's focal necrosis inside the adrenal carcinoma. So this is a necrotic cancerous tumor, which is the better kind. We do like cancerous tumors that are self-suicidal. We do like to give them a little help, but it's nice that the adrenal carcinoma has a death wish and eventually is unstable and can't support its own cells. So maybe it'll take longer to manifest ill effects from an adrenal carcinoma. Okay. All right, so that's all for the adrenal gland. We're moving on to the pituitary gland. So regular physiology of the pituitary gland, it's called the master gland. It secretes hormones that control all the other hormones and all the other glands, okay? Except for the hypothalamus. It turns out the hypothalamus actually controls the pituitary gland, so that's weird. But we'll see that in the structure diagram, okay? It is suspended from the base of the brain by a slender stalk, which is called the infundibulum. Yeah, I butchered that. We know where the pituitary gland is housed from the skull chapter in Radiographic Procedures 3. It is the resident of the sella turcica, which is at the top of, which bone was that again?
Oh yeah, it's the most superior and middle portion of the sphenoid bone in the center of your head. Yeah, you should know that for the registry. Okay, you like the throwbacks? Yeah, maybe there'll be more coming up. All right, divided into anterior and posterior portions, so it actually has hypophysis or hypophysis. I like hypophysis better, and neurohypophysis. And so front half, I would call that front half and back half, medical term-wise. Each part secretes different hormones, and we have a slide. So the anterior lobe or the adenohypophysis, see how it's in bold there? That's a big clue that you might need to recognize that on a diagram of the pituitary gland. Your adenohypophysis secretes growth hormone, thyroid stimulating hormone, adrenotropic hormones, and gonadotropins. So lots of things to do with growth and metabolism in the anterior lobe. And so if we see pathologies of those, we're going to see effects on metabolism and growth manifest in those pathologies. Okay. Gonadotropins include follicle stimulating hormone and luteinizing hormone. Those are in charge of or begin the stimulation process for secondary sex characteristics that manifest at puberty. Okay, regulation of the menstrual cycle, secretion of male and female sex hormones. Again, the secondary sex characteristics are kicked off by the gonadotropins, and also secretion of prolactin, which stimulates production of milk during pregnancy and after delivery. So all of that in the adenohypophysis, or the anterior lobe of the pituitary gland. Okay, so then next slide obviously is the posterior lobe. It's called the neurohypophysis. The neurohypophysis secretes oxytocin. Yes, that oxytocin. We have figured out how to synthesize that. You can still get addicted to it, but you can also secrete that. You can secrete that. That is also the drug of the runner's high, so to speak. So when you do a lot of physical exercise and aerobic exercise, you can actually stimulate your posterior lobe to secrete more oxytocin. It's a natural painkiller. It causes contraction of the smooth muscle, and it controls and strengthens the uterus during labor pains, and helps prevent hemorrhage after delivery. Okay. Also secretes ADH, which is a water-retaining hormone. Okay. Antidiuretic hormone, that's what that stands for. See? Yeah, just like you, I read it off the diagram. Okay. It's been a while since I've had pathology. I'm just telling y'all. So, all right. Hypothalamic neurosecretory cell. Okay, so it does have a connection to the hypothalamus superiorly. It hangs like a little grape on a grapevine, though. It's got a little stalk. Okay, and the front adrenopituitary looks like a glandular system, while the posterior pituitary, I don't see much in the way of ducts. Well, they're both glandular system, but one's got a network of ducts, and that would be the anterior pituitary. I don't see a network of ducts in the diagram. All right, so we get growth hormone, which stimulates the growth of bone. Adrenocorticotropic hormone, which stimulates the adrenal cortex to regulate salt and water metabolism, mineral metabolism, but also carbohydrate metabolism. Thyroid stimulating hormone stimulates the thyroid gland and its productions of T3, T1, T2, T3, and T4, and all the things the thyroid gland does. And so you could see how a pathology related to the anterior pituitary system would mess up a whole lot of systems. And then the gonadotropic hormones stimulate the reproductive glands, the testes in the male and the ovaries in the female. And then the prolactin stimulates the mammary glands in the female during pregnancy and immediately postpartum. Okay. Oxytocin, they call it stimulation of the mammary glands and the uterus, the smooth muscle, but oxytocin is also a natural painkiller. That is the drug, again, the drug of runner's high is oxytocin. All you got to do is exercise, and eventually you will get to a place where you don't feel you will feel like your joints will start to ache and your muscles will ache. If you keep going for another 10 minutes or so and then stop and drink some water, you will not feel any pain and it lasts about 2 hours. No pain in your ankles, no pain in your joints, no pain in your muscles. It's rather nice feeling. It's the best natural way to take a nap too. Oxytocin is also a suppressive, and it causes you to become drowsy. Right? Diseases of the pituitary gland. Now that we've covered normal physiology, hyperpituitarism, pretty straightforward. Hyper means above, and so it's a syndrome of increased activity of the pituitary gland, and then its opposite, hypopituitarism. And then diabetes insipidus, which is different than diabetes mellitus, and we'll go over those in the next 3 slides here. Let's go. All right, so hyperpituitarism. Now, I did steal this PowerPoint from Mr. Shepard, so he only had a picture of Richard Keel as Jaws from Moonraker. Moonraker was a James Bond film back in the late 70s, and so that was Mr. Shepard's frame of reference. But the same actor, about 40 years later, played the aggressive fan in Happy Gilmore, the one that was always taunting, who was that guy? Oh, Shooter McGavin, the bad guy in Happy Gilmore. So yeah, the aggressive fan was, and I love his shirt, by the way. The aggressive fan in Happy Gilmore, Richard Keel, star through the 70s and up through the 90s, suffered from hyperpituitarism. Also, another famous person suffering from hyperpituitarism was Robert Wadlow, who holds the Guinness Book of World Records for the world's tallest man at 8 foot 11 inches tall. Unfortunately, both of these gentlemen have passed away. So, hyperpituitarism results in acromegaly in adults and giantism in children. Okay. Acromegaly in adults, the most famous person suffering from acromegaly in the bottom right corner is the wrestler known as Andre the Giant. Also, God rest Andre the Giant. Okay. Acromegaly is characterized just by larger body parts, hypertrophic body parts, and it's pretty uniform all over the body. It is giantism. And a pronounced frontal sinus and superciliary ridge. So you can see this gentleman with I guess we're trying to hide his identity. I have no idea who the black man is with a black bar over his eyes, but he definitely has acromegaly. He's got that pronounced, and Andre the Giant also has that pronounced brow. All right, on the opposite side of the spectrum, hypopituitarism, profound generalized disturbances in bone growth and maturation. It is a form, not the only form, but it is a form of dwarfism, failure of the bones to grow normally in length or width. And so you have the person suffering from hypopituitarism has small stature, sexual immaturity, but they are well proportioned and of normal mentality, so it only affects their physical form. Kind of, not meaning to pick on this gentleman, I don't even know who he is. Kind of looks like a house elf, kind of looks like Dobby. So, for the Harry Potter fans out there. Okay. I'm not sure if Dobby has hypopituitarism. You'll have to check your Harry Potter lore on the internet. Okay. Diabetes insipidus is completely unrelated to diabetes mellitus, which is the more common type. Impaired ability of the kidneys to conserve water. And so, if we go back to the urography in RAD Procedures 3, I told you there was going to be throwbacks. Diabetes insipidus prevents the second part of the nephron cycles. So we know that the glomerulus pulls a lot of the blood plasma fluid, and because that's where the waste products are carried, and so a lot of the blood plasma pulls out from the capillary web. What was that called? Was it called? I think it was Bowman's capsule. That's what it was called. So the Bowman's capsule is the membrane surrounding the glomerulus. So the glomerulus causes rapid transfer of most of the water content carrying the waste products across the capillary network or the capillary ball in the glomerulus to dump the urea water into Bowman's capsule. And then that starts going down through the proximal convoluted tubule and the distal convoluted tubule and Henle's loop. And in the distal convoluted tubule and possibly in some of Henle's loop, that's when the kidney can choose to reabsorb some of that water and place it back in the bloodstream. Okay. But a person with diabetes insipidus, that physiology doesn't work right, and so they have polyuria, which is exactly like it sounds. You have to go to the bathroom, and you have to go a lot. Okay. This is low antidiuretic hormone, and so you don't get the reuptake of the water. The patient can run dehydrated from this. But it usually results in polydipsia, which is many thirsts. Okay, so diabetes insipidus is marked by one of the signs, or one of the symptoms, I would say, would be polydipsia. The patient always is requesting water or something to drink, and that's because they're always peeing. The kidneys are not turning off, and they are not reabsorbing water as they normally should. Okay. Second version of insipidus is where you are secreting antidiuretic hormone, but the kidneys are not utilizing it and reuptaking the water. And that's nephrogenic diabetes insipidus. It doesn't originate in the pituitary gland. It originates in the kidneys, and there's a flaw that they are not absorbing and utilizing the ADH. Okay. Thyroid gland physiology. So we are moving on to the thyroid gland. Normal physiology, T3 and T4. I don't know where I got T. Maybe I was thinking of MRI, T1 and T2. Again, I'm not that familiar with it. It's been a long time since pathology. So T3 and T4 will definitely be on an upcoming quiz. I have no idea about T1 and T2. Honestly, I was just spitballing. If there's a T3, why wouldn't that suppose the existence of a T1 and T2? That's all I'm saying. So T3 and T4 regulate body temperature, metabolism, and heart rate, in particular metabolism. Cellular metabolism is also stimulated. And so your ability to burn calories or exert more effort, or basically your stamina when you have been exercising or you have been exerting yourself, either mentally or physically, your thyroid gland helps to maintain your stamina and available supply of energy for your body. Thyroid gland also stimulates the secretion of digestive juices and movement of ingested material through the intestinal gastrointestinal tract, so it stimulates peristalsis and secretion of the pancreas and the other accessory organs in the GI tract and the small bowel. Okay. If you have thyroid gland disease, now I forget the name of this gentleman, but he was also a big movie star in the 70s. I forget the particular. He was in a Western, I think, with either Clint Eastwood or John Wayne. And he was always playing a sketchy character because of his guys, which is the layperson's term for, see that, what is that italicized word on the last bullet point there? Exophthalmos is bug eyes, okay? So if you have Graves' disease or hyperthyroidism, you will, one of the signs, because you can definitely tell if someone has bug eyes, it's either a yes or no, so it's a 1 or a 0, so it is objective measure. There are nodules. I'm doing this slide upside down. Nodules, hyperfunctioning or poorly functioning. Hyperfunctioning nodules demonstrate as hot uptake in nuclear medicine. Usually we're using iodine as the uptake. It is both, oh look, throwback to imaging equipment. Iodine 131 is both the radio tracer, but it's also the organic metabolic component of the radiopharmaceutical, all in one. Okay? It was one of the only ones that was that. All right, so here is a nuclear medicine thyroid scan, and we can see the thyroid gland and see those hot spots, increased uptake of the radioisotope. It should be a uniform speckle, like I know it's low resolution. Nuclear medicine is the lowest resolution of all because nuclear medicine is supposed to demonstrate function, not structure. So the increased uptake of iodine, especially in the lower half of these thyroid organs, indicates hyperthyroidism. Okay. Hypothyroidism is the antagonist or the opposite pathology to hyperthyroidism, and so you get cretinism. Short stature, coarse features, protruding tongue, broad flattened nose, widely set eyes, sparse hair, dry skin, protuberant abdomen with umbilical hernia. Cretinism is technically a form of malnutrition. If you live in, you see a lot of cretinism in underdeveloped countries because children are not getting supplemental iodine in their diet. Here in the United States, we supplement iodine in your salt, and we put salt on everything so no one suffers from cretinism. Okay. Hypothyroidism could also be genetic, but most commonly it could be severe birth defects, but it most commonly is lack of iodine in the nutritive process, starting in the womb. So mom can be running short of iodine in her diet and can cause cretinism in her unborn child. It can cause severe and irreparable mental defects, stunted growth, and reduced growth and function of many organs. It's basically a malnutrition, potentially congenital malnutrition syndrome that can be corrected with iodine supplements. Okay, and so here's some cretinism in Ukrainian women, and again, this was, if it says Ukrainian farm women, that's got a special place in my heart. Being a libertarian, I understood what happened to Ukraine during Joseph Stalin's reign, and it was absolutely hell on earth, and it's no wonder that the Ukrainian peasants suffered from cretinism during that time. He literally made them grow wheat for his army and didn't leave them any for themselves. And so he farmed the Ukrainian peoples to death, quite literally. And if you complained about your conditions and you're starving, he sent you off to the frozen tundra. Absolutely horrible man, Joseph Stalin. He is not a hero. He is not an idol. He might be the most evil human being to ever walk the face of the earth. Sorry, I digress. Here is inflammation, or not inflammation. It's an enlargement of thyroid, but it's not an inflammatory or neoplastic process. Goiter is also a sign of low dietary iodine. Okay, and you can see it comes with a nice set of bug eyes. What was that term again for bug eyes? Exothalamos, I believe. It's 2 slides back if you want to look. Okay, so goiter, exothalamos, both of those, they might show up in a matching quiz. I'm not crafting the quiz for this lesson, but I would put money down that both of those terms would show up in a matching quiz upcoming for this unit. Okay. Here's goiter on a radiograph. Okay, we can see now this is a straight AP, but we can see deviation. What is that black thing? Oh yeah, that's the trachea. Is it supposed to be way the hell over there? No, the thyroid gland is so hypertrophic with a goiter that it actually displaces the trachea from the midline. And so you see, first of all, you see an increased attenuation in the thyroid gland, and so you're going to slightly increase KV. It is still a soft tissue, and so it's not a radical change in KV, but it is an additive pathology. Goiter is, and you also see deviation of the trachea from the midline. That's a classic sign of goiter. Thyroid gland diseases, thyroid adenoma, encapsulated tumors, and these tumors could calcify. Okay, great variety in size of the tumors, compresses adjacent tissue, deviation or compression of the trachea with thyroid adenoma. Thyroid carcinoma are papillary, follicular, and medullary. All right, so here is an adenoma, and you can see the partial calcification or the mosaic calcification of the thyroid adenoma, and it does look like it's creating some pressure on the patient's trachea too. Looks like they're in the midst of a barium swallow while this is happening, so we want to looks like they're evaluating swallowing function. A tumor this size is obvious from across the street, so they definitely know this patient has a thyroid adenoma. They're just seeing if the esophagus is patent and they can actually swallow and eat with the size of this thyroid adenoma. So yeah, nice little barium bolus in the esophagus there, and it does look like they're getting the bolus down somehow, some way. So good for them. Hopefully they can remove that adenoma without too much difficulty. You can completely remove your thyroid gland and take supplemental hormones for the rest of your life, and so a lot of the pathologies are cured by surgery. Okay, in the case of a thyroid carcinoma, it's going to manifest like a hyperthyroidism. This is a nuclear medicine iodine 131 scan, so the thyroid does take up iodine, and it looks like the carcinoma is taking up more iodine than the rest of the thyroid gland that's healthy. So increased uptake. This is what's called a hot spot on a nuclear medicine scan, and it usually marks an increase in metabolic activity in the area of the hot spot. That's the physiology sign that you see from a nuclear medicine scan. So, and we know cancerous tumors have higher metabolic rates than comparable healthy tissue in their neighborhood. So, Parathyroid glands, so embedded in the thyroid glands, you might have heard about this all the way back. We're going to throw back to structure and function. There are tiny separate glands called parathyroids, which means around the thyroid, and I think there's 4 of them, 2 in the upper lobes, left and right, and 2 in the lower lobes, left and right. Oh, they call them poles. Yeah. Anyway, there's 1 in each corner. It's like if the thyroid gland was a 6-sided dice, you're looking at the number 4 face, and that's where the parathyroid glands are, is the dots on the 4 dots on the 4 face of a 6-sided die. Okay. They obviously secrete parathyroid hormone, PTH. Parathyroid hormone regulates bone growth and bone reduction. Okay, so calcium phosphate levels can increase or decrease in the bloodstream according to parathyroid hormone, but also bone remodeling can be stimulated by parathyroid hormone. Okay. All right, so hyperparathyroidism, you're going to do excessive bone remodeling. Okay. And we'll see a radiograph of that. Do you think that's going to be additive or destructive? What is bone remodeling? And those were I think, did we call those osteoclasts on the previous slide? Hypoparathyroidism. Excuse me, God bless. Hypoparathyroidism causes muscle cramps in the hand and feet, numbness and tingling in the extremities, which is basically the same symptoms for calcium deficiency. Okay, spasms of the laryngeal muscles can cause fatal obstruction of the respiratory tract in hypoparathyroidism. All right, for hyperparathyroidism, we're going to see subperiosteal erosion. Okay. That is excessive bone remodeling. Okay, and then in the adults, we'll see brown tumors. A brown tumor is excessive, rapid osteoclastic remodeling from excessive excretion of PTH. Okay, and so brown tumors are definitely destructive pathology. You can see how thin the bone matrix is in this knee radiograph. Okay, all right, diabetes mellitus. We're moving on to the pancreas. Diabetes mellitus is a failure of the aisles of Langerhans in the pancreas to secrete insulin hormone. Insulin regulates the absorption of glucose into the cellular metabolism. Okay, so glucose can't get into our body cells without adequate supplies of insulin, and so diabetes mellitus is a shortage of insulin or a failure of the body. If you have genetic diabetes mellitus or congenital diabetes mellitus, it's a failure of the body to utilize insulin effectively. Okay, and so without your body cells without adequate supplies of glucose, first of all, your glucose will start to build up in the bloodstream, and you will start to develop high blood pressure as a result of that, the hyperglycemia. But also, you'll have hyperglycemia, but you'll be constantly fatigued, and you will have trouble with cellular growth and metabolism. And so you'll be super skinny, but also have high blood sugar, chronic high blood sugar. Okay. Arteriosclerosis, frequent infections, kidney damage and failure, blindness. It turns out the blood vessels of the eye are very, very tiny, and chronic blood pressure situations causes focal ischemia in the eyes. Okay, and rupture of retinal blood vessels. Poor circulation to the nervous system may cause muscle spasms, tingling sensations, loss of feeling, intractable pain, and eventually paralysis. Insulin shock results from too much insulin and not enough food. So if you take supplemental insulin to regulate diabetes mellitus, you could go into insulin shock and your blood sugar could bottom out. You can go into diabetic coma that way. I had an aunt who suffered from diabetes mellitus. I've seen diabetic coma. It's usually reversible with hard candies. You can actually, now hard candies are a choking hazard. Orange juice is better, but if you don't have any orange juice, just open up they're basically going to look like they're comatose. Open up their mouth, try not to get bit, and put a root beer barrel under their tongue. And they will eventually come back around. Okay, just keep rubbing their arm and calling their name. I did this several times to my aunt. All right, complications of diabetes mellitus. We can see advanced arteriosclerosis in the bones of the hand. Oh, it looks like they're missing a finger. I don't think that's part of the pathology. But you can see the excessive calcification of the vessels of the hand. And then we also see focal necrosis of the soft tissue of the foot and osteomalacia manifesting in the fifth digit. And it looks like we've already lost some of the fifth digit. So if you take a radiograph of a diabetic foot and you see those air pockets, those are carbon dioxide bubbles from the bacterial colonies that are infecting the patient's foot. That is what gangrene looks like on an x-ray. And if you have that much carbon dioxide embedded in your soft tissue, you're going to lose your foot. Okay? All right, and then this is what it would look like in real life. This is gangrene. You can see the characteristic, especially that bottom left. Now we have had some debridement on the top left. Looks like some of the rotting flesh has been removed or has fallen off. Looks like we have weeping edema on the top right. We have necrosis of the toes. That's what the black is. That tissue is all dead. So we have necrotic flesh that needs to be debrided on the bottom left. And then looks like there is no soft tissue left on the bottom right. That patient needs an amputation probably just below the knee. It looks like you can clearly see their ankle joint, and the necrosis is traveling up their leg. So yeah, that one waited way too long. Rather than losing just a couple toes, they're going to lose their entire lower leg. It is tragic also for diabetic foot. Gangrene has an awful smell. If you haven't smelled it yet, you're in for a real treat, and it's such an awful smell that you'll never forget it. So God put that smell in there on purpose. If you ever smell that, yeah, you should take all your clothes off and do a survey of your body. Maybe call a friend to check out your posterior. Right. That is the end of the endocrine system pathology lecture. We talked about normal physiology of several of the glands. We talked about the adrenal glands, thyroid, pituitary, pancreas, and we talked about several pathologies, normal physiology related to those glands, several pathologies, how they affect the patient's body, and manifest signs and symptoms, but also how they present radiographically, not through just plain radiographs, but also through several modalities. Nuclear medicine was mentioned, ultrasound was mentioned. For some of the adrenal tumors, CT was mentioned. For the, I think it was the adenoma, cortical adenoma. Several vocabulary terms. We saw exothalamos, we saw giantism and Andre the Giant, and Richard Keel. We saw cretinism. We saw goiter. So several representative signs, recognizable signs of these pathologies that you'll be able to spot during initial assessment and interview of the patient. And then we also saw effects on plain radiographs. In particular, we saw a goiter is going to cause it's an additive pathology with a shift of trachea from the midline. We also saw some of the adrenal tumors showed up on CT as additional attenuating masses. The carcinoma has mosaic necrosis through the adrenal carcinoma. Remember that. And just remember, anything that's bold or italicized, you probably should commit that to memory for an upcoming quiz. And so hopefully you enjoyed my recorded lecture, and hopefully that gets Ms. Smith's class back on track. And we'll see you guys in registry review and digital imaging. Take care.